Thank you for the chairpersons. It was a wonderful session. Thank you, doctors. And next we'll go on to the plenary lectures. Now I'll call upon the chairpersons, Dr. A. Sundaram, Dr. V. Venkatratnam, Dr. Balaji onto the stage and introduce the speakers.
Good morning to all of you. At the outset, we all thank the organizers for this excellent practical approach to day-to-day management of diabetes. And today we have the second session with the three eminent speakers. The first speaker is Dr. Anand Moses, and he needs no introduction. He will be talking on just like 10 commandments. He is going to give 10 considerations to use DPP IV inhibitors for the initiation. Usually we initiate with metformin. Anand? Usually we initiate with metformin.
Yes.
So you are going to talk about SGLT2 as inhibitor.
No, not SGLT2, it's DPP4.
Yeah, DPP4.
DPP4.
Okay.
It's not initiation or anything. We have been using DPP4 for the past 1 decade. We know so much about DPP4. And when we write a DPP4, earlier it was the cost. And the three first DPP4s are almost the same cost. The new one is much cheaper. And still, how do we choose a DPP4? Until some time back, I was even just writing what comes to my pen, because there was not much choice between the three. And what I'm going to put forward now, 10 points about the DPP4 inhibitors, which are not new, but probably it may help you in choosing which DPP4 is the best for your patient. These are the 10 points, and I'll rapidly rush through these 10 points. First is why choose a DPP4 at all? Then among the DPP4, which one you think has an evidence-based approach? Why choose a gliptin? If you look at the pathophysiology of type 2 diabetes, what was 3 has become almost 12 now. There are so many defects in the brain, defects in the kidney, your fat tissue, your immune response, inflammatory things, so many things are there. And to have one drug addressing all these difficulties, pathophysiology is very difficult. Let us see. If you look at the list of drugs, like a metformin, TZ, all are good drugs, but if you look at the DPP4, it addresses most of the pathophysiology of type 2 diabetes. Most of the pathophysiology of type 2 diabetes is addressed by DPP4 inhibitors. Don't have time to go into each one and how it does, but this is a fact and most of us know this. Coming to the evidence and experience, we always write a drug by evidence-based medicine, and the 3 DPP4 inhibitors, that is your sitagliptin, vildagliptin, saxagliptin, and as well as linagliptin, have enough evidence to show on their safety and the various use. Probably sitagliptin, which is the drug which came out first in 2006, has more publications. And if you look at the global availability, the 3 major gliptins are available everywhere except probably vildagliptin is not available in the United States. And experience in humans, again, publications are more with sitagliptin, but both all vilda, saxa and linagliptin have enough evidence. Probably telinagliptin has less evidence. Then the DPP4 inhibition, most of the DPP4s, when they inhibit the DPP4, they are also likely to inhibit the DPP 8 and 9. And whether this has any significance in the treatment of diabetes is mostly experimental, but practically we do not see many of these points. This is regarding the selectivity of DPP4. There are some DPP4 inhibitors which selectively inhibit the DPP4 alone. Some are not very selective. They also touch upon the DPP8 as well as the DPP9. And experimental studies have shown that when you inhibit 8 and 9, there are possibilities of reducing the immunity as well as the atherosclerotic process, as well as some of the malignant progression of tumors. All these are shown in experimental animals, though not proved in humans, but the fact is there. So among the DPP4s available, which one is most selective? If you looked at sitagliptin, it's got 100-fold selectivity of DPP4, as well as the fibroblast activation protein, which is responsible for malignancies. Yes, the highest selectivity is sitagliptin, but the others, all the other gliptins, including the telinagliptin, has moderate selectivity. That is, majoritarily it reduces the DPP4, but it also touches the 8 and 9, about the impact of which we do not have any evidence now. So DPP4 inhibition, what matters? So what should be a good DPP4? It should have once a day, you just give it once a day, the next 24 hours, it should suppress the DPP4 activity as much as possible, and it should be more selective. Let's see which drugs have the highest DPP4 inhibition over 24 hours. Of course, sitagliptin as well as vildagliptin. Vildagliptin may show us 28, but when it given at twice a day, it has almost a 90% inhibition for the next 24 hours. If you look at this, the top two, the first one is sitagliptin, yellow one is the sitagliptin, the other one is vildagliptin given twice a day. Vildagliptin given twice a day is equal to sitagliptin once a day. The other gliptins have less selective. Yes. Coming to, can we really compare the efficacy based on evidence? There are evidence with all the gliptins. I have just selected sitagliptin as one of the drugs. And if you look at the most of the anti-diabetic medications, and if you look at the HbA1c lowering effect, almost all, right from your metformin, sulfonylureas, everything is around 0.8 to 0.9. It's all 0.5, 0.5. So there is not much of a difference. It is only how it does it without complication. Side effects is a difference rather than the real HbA1c difference. If you look at metformin, sulfonylurea, the only gliptin proven to be effective as other conventional OADs. Almost all the DPP4s have almost the same glucose lowering effect. Efficacy in comparison, when add on to metformin, as you can see, all of them reduce HbA1c by 0.5 to 0.6. So there's not much of a difference among the gliptins. But when you have it as a third drug, probably when you have a sulfonylurea and a metformin and you add a DPP4 as a third drug, probably sitagliptin scores over little because of the little higher efficacy. Then coming to the durability, durability is of any drug is how long the drug works, keeps up the HbA1c lowering effect. As you would have seen, sulfonylureas have a good HbA1c lowering effect for the first few years. After that, the curve slowly starts going up. So the durability is an important factor. Again, all DPP4, most of the DPP4, particularly vildagliptin as well as sitagliptin as well as linagliptin, have good durability over 2 to 3 years. But the drug which has been shown to with the longest durability, that is for over 4 years, working at the same level, keeping up the HbA1c at the same level, is probably sitagliptin. Sitagliptin plus metformin has a 5 years durability. That doesn't mean the other DPP4s have, but this has a little more durability than the other gliptins. Coming to the drug interactions with gliptins, whether very little drug interactions, fortunately gliptins are drugs with very little drug interaction. So only drug interaction what I would call as, if you have a patient on sulfonylurea and metformin, the chances of getting hypoglycemia is more. That is probably the single most important side effect I should call you. But there are small differences with saxagliptin and linagliptin, which are strong CYP inhibitors, where when you use ketoconazole or rifampicin, the dose has to be adjusted. Particularly linagliptin, we try to avoid linagliptin when a patient is on rifampicin. Coming to the point number 8, how you choose a gliptin, look at the comorbid conditions: diabetic, kidney disease, and hepatic disease and CVD. I think all this, number of studies have come out on all this. If you look at the DPP4 and CKD, sitagliptin is minimally metabolized, and linagliptin is again minimally metabolized and excreted. So the safe drugs to use, almost all the DPP4 inhibitors can be used in renal failure, but linagliptin is one drug where you don't need a dose adjustment. Sitagliptin, vildagliptin and saxagliptin dose has to be down titrated when you use in a patient with renal failure. Telnigliptin also has now some evidence to show that it is probably quite safe in renal failure, and a dose adjustment may not be necessary with telnigliptin also. Though the studies are not robust, there are small good studies which are showing that. Coming to gliptins in new onset diabetes after a transplant, these patients are on tacrolimus or sirolimus And then we would like to know whether when you put a DPP4 inhibitors, whether these levels are altered. These are some small studies which have shown with sitagliptin that there is no significant change in tacrolimus or sirolimus levels. There is no significant alteration in EGFR, and there is a good point for HbA1c reduction. So DPP4 inhibitors, particularly if you want to go by evidence, sitagliptin has a good evidence that it can be used in NODAT, that is diabetes following a kidney transplant. Coming to the hepatic impairment, if you look at the metabolism of these drugs, sitagliptin is minimally metabolized in the liver. Vildagliptin is extensively metabolized. So vildagliptin is one drug which we generally try to avoid in hepatic disorders. As it is, if you look at vildagliptin, even in normal patients, it causes a slight increase in hepatic enzymes when you use vildagliptin. There is a reason why vildagliptin is given as twice a day, split. When the drug was first introduced, it was given at 100 milligram once a day, and it showed almost 2.5 times increase in hepatic enzymes. So when they cut the dose and divided, it is less. So still there is a slight rise. So whenever patient has an existing hepatic disorder, we try to avoid vildagliptin. Linagliptin is probably very safe again. Though it's minimally metabolized, primarily it is excreted by hepatobiliary excretion, and there doesn't seem to be any problem. Telnigliptin, it is claimed in the small studies it is quite safe in hepatic disorders. So what are the approved indication? I think I already told you, sitagliptin, vildagliptin should not be used. Telnigliptin has very little robust data. Gemigliptin is not there anymore, so we won't talk about it. Coming to NAFLD. NAFLD, it has been shown that DPP4 activity is high in NAFLD. How this directly influences the NAFLD, we do not know, but there are studies to show it is elevated. And does using a DPP4 inhibitor helps in some of the progression of NAFLD? There are some small elegant studies done. This study has been done with sitagliptin. The number may be small, but it has definitely shown there is a good HbA1c reduction, a small HbA1c reduction, a small reduction in the liver enzymes, and the ballooning, which is also said to be less of ballooning of the liver cells, which leads to NASH, as well as NASH score also comes down. So there will be a marginal benefit in NASH, though it may not be great. At least we know it is quite safe to use in NASH. Coming to the CVD, this is the last point you consider before you use a gliptin. There are 3 large elegant studies. I think most of us have heard about all these studies in many of the lectures, the SAVOR, TIMI, the EXAMINE, and the TCOS. These 3 studies were started because this was the time when the FDA mandated that any new anti-diabetic drug should go through a cardiovascular safety profile. Because of the rosiglitazone episode, this became mandatory. So these 3 large trials have come out now. We have one more trial, Carolina, which has recently come out. And uniformly, these showed that the 3-point MACE and the 4-point MACE is almost same. There is no increase in 3.4. It's cardiovascularly, all the gliptins are almost safe. But when the SAVOR-TIMI trial came out, there was a small indication of increased heart failure in patients who had already existing heart failure, increased admission for heart failure. So this triggered a response. Probably today we are seeing talking so much on heart failure and diabetes is because of the SAVOR-TIMI trial, which opened our eyes that some of these drugs could induce heart failure, precipitate heart failure. And one such drug is the saxagliptin, and the FDA has given a black box warning that this drug should not be used in heart failure. And later now the FDA has generally given, if the heart failure is there, try to avoid generally a DPP4 at all. So to that extent, heart failure, there is an indication. Then if you look at EXAMINE trial, allogliptin, it never came into our country, but it's available in the United States. And then allogliptin also showed an increase in heart failure, but it was not statistically significant, but definitely it showed an increase in heart failure in admissions in patients with a pre-existing heart disease. So these 2 drugs should be careful. We do not know whether it's a class effect or it's a individual drug effect, because when the TCOS study came out, it showed that it did not have any influence on heart failure. It was neutral in heart failure. TICOS luckily was neutral. So at least from the available evidence we know, probably if you still want to use a DPP4 in a patient with pre-existing heart failure, probably I would go by the TICOS trial and choose a sitagliptin just by the evidence, not by experience, just by the evidence to show that it is safe in heart failure. Then this is a study from Israel which showed the protective effect of DPP4, but particularly sitagliptin in hospital complications in patients who are taking DPP4 is less when compared to metformin and other drugs. The hospital stay is less. So the gliptin to use in patients with history of heart disease, sitagliptin, no specific concern or warning even in patients with CVD or even heart failure from the TICO study. Vildagliptin, unfortunately, does not have a large study. It has a small study called the VIVID study in Europe. Again, this study also showed a slight increase in cardiac failure, though it was not statistically significant. Saxagliptin, no increase in CV events, but of course, heart failure is a concern. Linagliptin, the studies have come out, the Carolina, but the subgroup analysis on heart failure is yet to come out. Probably the next 2 months in the ADA will have more light on linagliptin and heart failure. And telnigliptin, there is no cardiovascular outcome study. We go only by our experience. So finally, coming to DPP4 inhibitors, it's a first in class. I mean, sitagliptin has a largest number of studies, and the largest, I think we are all also much experience with sitagliptin. It's a truly once a day DPP4. It can be taken at any time, monotherapy, and which has a long durability, and the safety has been well established. So DPP4, most of the DPP4s, finally, I would like to say, are quite safe in most of the situations. But these finer situations like heart failure, renal disease, and hepatic disorders, if you know to adjust the drugs and what drug to use, then DPP4s are quite safe. Thank you.